Today, we are tackling something that is, well, it's absolutely core to digital healthcare, but it's also famously complex. We're talking about SNOMED CT.
And we have to start with what it is not, because that's where the confusion always begins.
Right. It's not just another coding system.
Exactly. People hear standard and they immediately think of things like ICD, which is for billing, and broad statistical grouping. That's like a library's Dewey Decimal System.
A way to find the right shelf.
Right. Some SNP is the index inside every single book. It's the incredibly detailed, multilingual clinical language for what a doctor is actually thinking at the point of care.
Okay, so if it's a language, how do you make it one a computer can actually understand and, well, reason with? It can't just be a huge list of terms.
It's not. And that's the critical part. It's a formal ontology. It's built on a mathematical framework called description logic, which basically gives it machine-readable grammar.
A grammar, I like that.
Yeah.
So what are the nouns and verbs of this language?
You've got three main parts. First, the concept's unique ideas, each with a code. Then descriptions, which are the human-readable terms for those concepts, with like the fully specified name. And then the most important part, relationships.
But if you build this huge network of relationships, doesn't that risk, I don't know, making the whole thing slow and clunky? In real-time care, you need speed.
That is the exact trade-off they had to solve. And they did. The system uses a very specific, computationally efficient subset of description logic called EL++.
EL++.
It's designed to be powerful enough for complex clinical ideas, but simple enough for a computer to process almost instantly. And that speed is what makes the whole concept of a polyhierarchy possible.
Ah, the polyhierarchy. This feels like the real aha moment.
It is.
Yeah.
In a simple hierarchy, something has only one parent. But in medicine, that just doesn't work. Is a skull fracture an injury, or is it a skeletal disorder?
It's both.
Exactly. And SNOMED CT's polyhierarchy lets a computer understand that. So bacterial pneumonia is a type of pneumonia A&D. It is a type of bacterial disease. That allows for an inference called subsumption.
So the system can automatically figure out that this specific thing belongs to multiple, broader, clinically relevant groups.
Without anyone having to program it explicitly. It just knows.
And that level of detail, that granularity, is an absolute must-have for something like a clinical decision support system, isn't it?
It's non-negotiable. Without it, a complex condition is just an opaque label to the computer. It can't reason about it, can't check for drug interactions properly, can't do anything smart.
And this need for speed and detail has actually changed how the standard is managed, right? I was really struck by the shift in the release schedule.
Oh, massively. They used to do biannual releases, which is just, it's too slow for the modern world. As of September 2023, it's a monthly international release cycle.
Monthly. That's fast.
It has to be. Think about tracking a pandemic in real time or constantly updating the machine learning models that hospitals rely on. You need that velocity.
It's a clear signal that this is about live operational interoperability. It acts as that semantic content layer for standards you always hear about, like FHIR.
It's the meaning layer for FHIR, especially in things like the International Patient Summary. It ensures that when data moves, the clinical meaning moves with it, unambiguously.
And for AI, it's foundational.
It's everything. When you use natural language processing to pull information from a doctor's notes, SNOMED CT is the structured target you map it to. It's how you make sure the AI's interpretation is clinically safe and actually correct.
So let's bring it all home. SNOMED CT is this definitive semantic layer that's enabling everything from global data exchange to the next generation of clinical AI. But the sources we looked at pointed to a really big, persistent problem.
The implementation gap. And this is the provocative thought we should leave you with. We have policies that mandate the adoption of SNOMED CT. That part's done. But true interoperability is still failing.
Because different hospitals are implementing it in slightly different ways.
Subtle, inconsistent ways. So the question becomes, how do we shift the focus? How do we get from just mandating adoption of the standard to rigorously enforcing adherence to its deep technical rules, like the machine-readable concept model? Because until we solve that, the true promise of computable healthcare is going to remain just out of reach.